on the phone? They might be in a position where they can't speak because maybe they're on the road. But most of the people I got that were on the phone, we know are also in the room. Like Margaret and Michelle are actually both also in the room and on the phone. So it's just the 918 I didn't get.
And then, Tony, I'll send you a message and see if there's any way I can keep these archived, cardiac, respiratory, and then the neuro for next semester. But I'll write you an email about that. We talked about that last semester, and I didn't go anywhere with it. So thank you.
Sure, yeah, just follow it up, and we'll look into that. That's fine. Thank you.
Okay, Ellen, did you want to go through first and talk about what you want, or is it okay if I go first? What works for you? Well, we can't hear Ellen. Ellen, if you want to write to us, that's fine too. Okay, here's what you do not need to know about diagnostic tests. So I thought it was important to tell you what you don't need to know initially. And so what do you need to know for for lab tests? So what is sensitivity? Anybody, and feel free to write these answers in. I won't remember who, thanks, Ellen. I won't remember who said it or didn't say it. Remember that if you're trying to remember something, I think I've told you this before, if you say it out loud to yourself, you'll remember yourself saying it. Ellen, are you on the phone? Are you the 918 number?
No, can you hear me now?
Yeah, we can hear you now.
No, I'm not the 918 number. I don't know who that is.
Yeah, I just said it because that person needs to mute their phone because we're hearing the background sound from the phone.
Did you mute your phone, 918? Okay. All right. What is sensitivity? Anybody?
True positive?
Right. It's a probability that if you really have the disease, the test will be positive. And when you're remembering two things that are dissimilar, your goal is to only remember one of them. So if you remember sensitivity and you know that one, then specificity is the opposite. So if you think of sensitivity, it's very sensitive. And when you're sensitive, you're patient. And if you're patient, you're positive. Thanks, Tony. So that's sensitivity. So what's the opposite? What's specificity? True negative, right. And when we say true negative, your goal is the probability test of negative is if the disease is negative. And true negative, you're talking about 1. And when we talk about the number 1, and so you might have a 75 or a 97 or 85 sensitivity and an 82 specificity. And so you just need to know those numbers. And you can ask your preceptor if they even use that. But you need to know that because some tests are neither sensitive or have less value as sensitivity and specificity, and we still tend to use them. Now, what is the gold standard test? Oh, Michelle, thank you, TTT. Usually that's the diagnostic test that rules it in or rules out the disease. Some students presented some PowerPoints last night, and they used the gold standard treatment approach. And gold standard is usually used for the test. And so, and an example would be if somebody comes in with pneumonia, what is the gold standard test? And that's you do a culture of the sputum and you treat it specific to what grows out of the culture plate. Lisa said that her friend just did the acute care nurse practitioner exam and said they did a lot on the positive, negative, and probability theories. And you need to know that, but you'll know that in 680, and that's something you can teach yourself. You can read about it. You can look it up on Google, and there's lots of information on how to get positive, negative, and probability theories. So anyway, if somebody comes in with a pneumonia, we can talk about getting a sputum and doing the culture and sensitivity, but the problem is the sputum has to come through the throat, and not everybody is a good cougher, so you tend to get the floor of the mouth rather than the sputum from the chest, so we don't use that. We use a chest x-ray. So even though we have a gold standard, we don't always use the gold standard. So if you need a gold standard for the test, what options do you have to know the gold standard? You can look that up. Sure, you can just put gold standard for the test and look it up. But the other thing is, I'm hoping that most of you have iPhones or some kind of phone where you can look up in either up-to-date, Hippocrates or Medscape, and you look up the disease and it gives you the gold standard. It gives you the sensitivity. It gives you the specificity. And yes, you need to know that. I use Medscape. A lot of people use Hippocrates. It just depends what works for you. And I don't find that patients are ever angry that I choose to use that resource. Now, the other thing is you do have to memorize stuff. You'll find that when you're working with a preceptor, any of your preceptors or physicians, they can quote long discourses on lots of diseases. And in the old days, and that just sounds like in the 90s, when I went to school, I had to quote all that stuff too. Our Bible was the Washington Manual, and you had to know it inside and out. It was very dog-eared by the time I left. And I wrote everything down. I had a little black book. I could pull it up. I knew all those things, and I had them memorized. And even nowadays, if you're working with physicians, they can quote all kinds of stuff that I can't quote, because they used to memorize. So you should be able to memorize a few things, especially the sensitivity and specificity of the test you use most often in whatever clinic you end up using, or you end up being employed in. And an example would be in the cardiac lab. You need to know what's the sensitivity and specificity of a stress test, for a female, for a male, for the age, for the body type. You need to discuss that with patients when you order a test to see, are they going to find out, do they have the disease? Don't they have that disease? And so those are things you need to know. So the cost, and how do you look up the cost? Yes, you can just Google the cost. Or, I'm not talking about the DRG, the cost of the test. Whether in your facility it's better to run a TSH and a T4 or a thyroid panel. What's the difference between running a CBC with diff and a CBC without a diff? If you order an iron panel with a saturation or not. So that's the point, is that you should know the cost. So what I'm talking about for the midterm exam, these are the things you should know about lab tests: the sensitivity, the specificity, the gold standard diagnostic test, the cost of the test. Now, I'm not going to ask you the cost of a UA versus a gram stain. I'm saying, should you know it? And the answer is yes. The other is, what is the patient preparation for the test? Do they have to fast for the test? I mean, it's like lipid exams. I don't think there's, depending on what you read, it's between 5 and 30% difference in your LDL versus fasting, non-fasting, whether it's 12 hours or 14 hours. Some people cannot not eat for 12 to 14 hours. A 24-hour urine, you have to go over what is the patient preparation. Once you start ordering CT scans with and without contrast, you have to talk what is the patient preparation. If you order an MRI and they have metal in their body, what is the patient preparation? So those are the things that you need to know. Then you need to know the benefits and risk. If you're looking for something and you find it, How do you provide that information? I think I gave the example. We had an 89-year-old that came in the hospital because he hadn't eaten for 2 days, and he was he had dementia, and he also had delirium in the hospital. And his chest x-ray had a 5 centimeter nodule, and the family wanted it worked up, and the doctor said the benefit to the patient was minimal. The risk to the patient was huge in terms of emotional cost, time cost, financial cost, and he recommended not working up the nodule. And sometimes you need to know this. And this is an important thing for you to know about cancer screening, is when do you start or stop cancer screening? Do you do a colonoscopy after the age of 75? When do you quit doing a mammogram? When do you quit doing a pap smear? And you need to know those things. And you talk those over with a patient. Do you even do a PSA test, a free PSA test? And that's what I'm saying, is that you need to know the benefits and risk of the testing, the cost of the testing, and the results of testing, and determine, does that help you determine the diagnosis or the treatment plan for the patient. So this is just another slide on what do you need to know, and it's what I went over. And my goal in these slides is just to give you some more slides, some pictures. Some of you learn by pictures, and that's how you remember. So what are some lab tests you need to know? One of them is for anemia. What's the most common type of anemia in the United States, and how do we determine that? Right, iron deficiency anemia. And Sarah, how do we look at that? What is the definition of anemia, by the way? A hemoglobin below what? Right, 11 or 12, depending on where you are, and it's based on excellent the gender, ethnicity, and the age of the person. So that's always important, but it's either 11 or 12. And so with iron deficiency anemia, how do I determine that? What is specific about the CBC that lets me know that? And it's in the differential. It's in the indices. What indice tells me that? And MCV is what? The size. So if it's micro, then it's iron deficiency anemia. And if it's macro, what is that? B12. Excellent. And so this is just what I'm saying to you. You should be able to determine anemia. Now, you don't have to be able to tell me hemolytic anemia. You don't have to tell me sickle cell anemia. But the goal is, when you order a CBC and you look at the indices, which indices allows you to determine what kind of anemia is. And yes, for iron deficiency anemia, you do look at an iron panel and you look at ferritin and saturation, but I'm not asking you that today. I'm just saying which indice allows you to understand if it's micro iron deficiency or macro B12. Thank you. There is an anemia called normocytic normochromic, and that's the right size and the right shape, and that's ACD, anemia of chronic disease, and sometimes people consider aging a chronic disease. Just thought I'd throw that in. So this is a CBC with DIF, and in our hospital, DIF is a lot more expensive than just a CBC. So sometimes people are only looking at the H&H, and you need to know with your preceptors, and this isn't on the midterm, what is considered what do they look at for transfusion? Do they look at the hemoglobin? Do they look at the hematocrit? And what are the benefits and risks of transfusion? Some people say you transfuse at 7, depending on what the age, gender, and ethnicity and the comorbidities of the patient. Retic count is your small red blood cells, and if the retic count is elevated, then you know that the body is responding to the anemia, so that's important. Platelets aren't cells. They are just fragments, and when they go together, they cause clotting. Low platelets would be thrombocytopenia. Too many would be thrombocytosis. Remember, penia means little. I don't want to go any farther other than to say that. And so you need to know with if somebody has thrombocytopenia, meaning low platelets, what would be the causes? There's primary and there's secondary, not for this test, but for any of the specific red blood cells, white blood cells, if they have too few or if they have too many. Is it because they're failing to produce them or they're destroying them? Then we talk about what are the tests that we use to look at different organs. So when we go to look at the liver, what test do we look at for the liver? Give me some answers. AST, ALT, excellent. Alk Phos is mainly bone, but it's AST and ALT. Excellent. Hepatic panel, correct. But you should know AST and ALT. ALT probably the most specific. And then for the pancreas, what test for the pancreas? Lipase and amylase, because you want to rule out acute and chronic pancreatitis. And excellent. And what do we look at for the kidney? Well, you look at the BUN and creatinine, not the BUN. The BUN kind of tells you what the hydration status is, and it will tell you pre-renal, intrarenal, or post-renal, and it has to do with the BUN creatinine ratio. But you look at the BUN and creatinine, and the creatinine is going to tell you that based on, correct, the BUN creatinine is going to tell you an estimated GFR. There is a Cockalt graph GFR that puts in the age, gender, and ethnicity, and it gives you a better estimation of what the GFR is. But it kind of tells you if it's below 50 or above 50, below 30, below 30, based on the age, gender, and ethnicity. So BUN and creatinine to determine kidney function to give you an estimated GFR. Excellent. So what do we look for in the urine? Blood, and blood is hematuria, and you have fine and gross osmolality. How do I determine a urinary tract infection? Why don't we focus there? Urinary tract infection. What are we looking for? How do we determine urinary tract infection? Got lots of answers here. Sure. And it's usually 5 to 10 WBCs, thank you, and either positive nitrates or leukocytes. So that's for a UTI. So you're all going to look up, how do I determine a UTI? And I'm so impressed with everybody's answering. Thanks. So now we're looking at the respiratory system, and that goes from the nose, the mouth, down to the base of the lungs. Your respiratory assessment, remember, most of the time somebody comes in with a respiratory problem, and you have to rule out as a respiratory and or respiratory and cardio because they work together. You probably have a focused exam. You get a history of the physical illness. You do PQRS or QRST. You listen to signs and symptoms. As they're giving you those, you're thinking of what the differential diagnosis is, and then you're trying to determine that the risk factors are for a specific disease. And what is a risk factor for a respiratory disease? Smoking, correct. Age, gender, ethnicity, and smoking. Excellent. So you inspect. And what do you inspect for in respiratory assessment? Yes, family history. Correct. You inspect for the rise and fall of the chest and use of accessory muscles. You look at nasal flaring. You look at the position of the patient, whether they have tripod sitting so that they can breathe, or whether they're back in the chair, or if when they're talking, if they're breathing in between the words. I had a patient come in today, and he was just so concerned about, he's an 85-year-old professor, and he's so concerned about his kidney function, and he continues to smoke. And he talked to me, and he couldn't say 4 words without gulping air and using his whole body to breathe. And I brought that up to him. I said, "You have such trouble breathing." And he said, "No, I don't." And I go, "Well, you actually do. How far can you walk?" But it was kind of amazing to me. He just didn't know how much energy it took him to breathe while he was talking. Okay, what do you palpate for? Fremitus, tactile fremitus, and yes, you palpate the sinuses. Thank you for bringing that up. And tactile means touching, and 99, 99, 99. And what part of the hands do you use for tactile fremitus? The ulnar aspects, thanks so much. And you compare the right versus the left. And then when we percuss, what are we percussing for? For fluid consolidation, and you're going to hear a different sound. And you use the third finger, and you can either use a reflex hammer or your other hand. And so are you percussing on yourself? Can you determine tympany? And tympany is usually in the stomach. Remember, tympany is air-filled. And you can palpate over bone and over your thigh. And that's T-H-I-G-H, thigh down here in the south. And over air. And then we auscultate. And how do we auscultate? What's the patient preparation for auscultating? Right, posterior, and you ask them to breathe out of their mouth. Excellent, Michelle. And take low, deep breaths in and out. And I usually listen 4 times on the back if they don't come in for a respiratory distress. If they do, you want to really listen to the 8 places. And you should know the difference between bronchial sounds, bronchovesicular sounds, and where they're found on the body. And I know we talk about the bell and the diaphragm, but with my stethoscope, I don't have to worry about the bell and diaphragm. I just either firmly place it on the chest or lightly place it on the chest. And I can listen through close and actually hear. And so if I was hearing adventitious sounds, what would be examples of adventitious sounds? Wheezing, and wheezing's related to what? Wheezing's related to water, and yeah, it's obstruction, it's air trapping. And so you listen, and then if they're wheezing, what do you ask them to do? To cough. Does it clear with coughing? And you want to determine, is it inspiratory wheezing? Is it expiratory wheezing? And then if you use rails, rhonchi, coarse rails, fine rails, does that really matter in your language? Is somebody going to tell you you're wrong? No, because it is what you hear. And you listen on the back and you listen on the front. And where do you listen for the right middle lobe? Yeah, underarm. Axial. How about axilla? There we go. And so there's 3 lobes on the right and 2 lobes on the chest. And you can do a diaphragmatic, I'm blanking on that, excursion using your hands, but I'm not asking you to talk about that. So we've said inspect the position of the patient, the use of accessory muscles to palpate, and that's tactile fremitus, to percuss, and you're percussing, comparing the right and the left, and it's usually on the back, and you're listening for consolidation or any change dullness in there, and then auscultate for breath sounds in and out, and then any adventitious sounds. And if you hear any adventitious sounds, you want to know if they clear with coughing. And if you record it, you would say where it is correct in the lower bases or in the upper bases, right greater than left, clears with cough, does not clear with cough. And yes, when you do a normal exam, whatever that means, although you can't write normal, you put CTA, cleared auscultation, A&P, respirations, even in unlabored. So the ones we look at are asthma and COPD. Asthma is considered reversible. COPD is bronchitis and emphysema, and it's non-reversible. Now, I'm not asking you to define those. I'm not asking you to give me the risk factors. I'm not asking you to give me the treatment plan. I'm just will give you a scenario, and you should know, is this asthma? So what is the criteria that you're listening for in an HPI for asthma? Yes, the answer is wheezing. Thank you all for doing that. And for COPD, what would be the risk factor that's mainly associated with COPD? Smoking, correct. And you can talk about the blue bloaters, the bronchitis patient that usually has a big stomach and they're coughing all the time, or the emphysema patient, which is a cachetic looking individual and they're called the pink puffer, and they have air trapping and they're different, but COPD is associated with smoking and it's not being able to breathe. So these are the classification of asthma. What you should know is that every asthma patient, and asthma is a myriad of diseases related to wheezing, and it can be diagnosed at any age. It can actually clear up, is that everyone should have a stage of should be staged, and they should have an action plan. And so I would say that for asthma as well as COPD, staged and an written action plan to either step up or step down. Once again, and this is just saying what is COPD and bronchitis. So if I was diagnosing COPD based on the FEV1 over forced vital capacity, what would that diagnosis be? It would have to be less than what I've predicted. No, Lisa, you don't always need PFTs to drive the action plan for asthma, but you do need to for the GOLD. Once again, I'm going to diagnose COPD, and you actually do it with a flattened diaphragm on a chest x-ray. But if I was looking at the spirometer, the PFTs, what is the criteria for diagnosing COPD? FEV1 over the forced vital capacity ratio is less than what? Excellent, 70% of predicted, right up there, under 1, 70% of predicted. So we talk about dyspnea, and what's the other word for dyspnea? Shortness of breath, excellent. And so what do you have to determine in dyspnea since it's so subjective? You need a dyspnea scale, correct. So you need to find out how much can they do, and that's the biggest thing. How much can you walk or do without getting short of breath, and then how long does it take you to get better? So what do you want to rule out? And for the next couple of diseases, I'm going to say the same thing. What is the most important when somebody comes in for dyspnea? What are the 2 deadly diseases that you want to rule out first? Correct. And you have to say acute coronary syndrome. MI is not what we say. Remember, we're nurse practitioners. ACS and PE, acute coronary syndrome and PE. Yes, pneumonia has high mortality, but this is what you're saying, especially if it's acute on dyspnea. And the same with chest pain pressure. It's deadly till proven otherwise, acute coronary syndrome or PE. Now, there's also the thoracic aneurysm that's dissecting, but I'm just focusing on these 2 things, ACS and PE. So now we have the cardiac assessment, and we inspect. What do we inspect for in cardiac assessment? Well, first thing we do is we look at the skin color, okay, the skin color, and we look at temperature, because remember, the goal of the heart is to perfuse the body. So we look at those things. Great. And after we look at the skin color and temperature, then we can palpate. And what are we palpating for? The PMI. And where is the PMI mostly? Fifth intercostal space. And if it's not in the fifth intercostal space, it's over to the left. What do I think I'm going to see on a chest x-ray? Left ventricular hypertrophy. And what is the leading cause of left ventricular hypertrophy, which is different than a balloon heart? Hypertension. Excellent. Hypertension. Okay, then when we auscultate, we listen to S1 and S2. And remember that S2 splits with the young person, and so you have to ask them to hold their breath to see if it splits. So you're listening for normal heart sounds, S1, S2, S3, and S3 depicts what? CHF, and S4 is associated with what? Right, acute coronary syndrome. And remember, S3 is due to CHF. It's found in diastole. It's usually due to ventricular overload. That's why it's with CHF. And then we look for murmurs. And what is another way to describe murmurs? Turbulent blood flow. Correct. And so the blood is going back into the chamber it just left. And so we talked about the main ones we hear about are the systolic, and that's mitral regurg and aortic stenosis. And an incompetent valve is a valve that fails to close. A stenotic valve is a valve that fails to open. And so those are the two reasons for murmurs, okay? There's a pathological murmur and a non-pathological murmur. What age person would have a non-pathological murmur? Mainly. A newborn, correct. It's called a flow murmur, an innocent murmur, although anybody could have that, okay? Flow murmur, innocent murmur, and then you have a pathological murmur, moo-moo. But what I'm just saying is there's two types of murmurs. Innocent murmur, which is a flow murmur, and a pathological murmur, meaning that there is a change in the valve. It either fails to close or fails to open. And so that's what I'm asking you to tell me about. And then when you auscultate, you hear an S1, an S2. If the S2 splits in the young person, you ask them to hold their breath and you listen. If you hear S3, that's an extra heart sound. You associate that with CHF and diastole, fluid overload. If you hear an S4, you're going to see that it's a gallop and it's usually an ACS. And then the peripheral vascular assessment is you look at and you feel the temperature and tone of the right and the left side of the body, the upper extremities, the lower extremities. You start with the carotids, and you can feel the radial pulse and the DP pulses, and then you assume that the brachial pulses as well as the femoral pulses and the popliteal pulses are intact. You also want to auscultate over what part of the body that's in the abdomen. The aorta. Thank you so much. And then when we talk about cardiac events, we mainly talk about hypertension, which is the leading cause of cardiac or coronary artery disease in the United States. And how do we determine if somebody's hypertensive? You have your JNC7, and then I think in December 2013 came out the JNC8. It's saying on two separate occasions you find an elevated blood pressure. That's important for you to know. It's important for you to know modifiable and non-modifiable risk factors for hypertension. I'm not asking you to tell me what are the 4 categories of drugs and who do you use it on, but if I ask you when selecting a drug, what would be the considerations you would have for selection of a drug for hypertension? And the answer would be what 3 criteria? Age, gender, and ethnicity. Thank you. We talk about cardiac risk factors because your goal, because heart disease leading killers of females, is what are the modifiable and non-modifiable risk factors for cardiac disease. You can either use the Framingham risk calculator or the pooled cohort equation, which takes into account African Americans. You get a 10-year risk and you get a 20-year risk, and you determine if they're low, moderate, or high risk. Remember, I'm just giving these concepts to you, and then you determine what's modifiable and non-modifiable, and you partner with your patient to see what they're willing to change. Syncopal flow chart. If somebody comes in and they've had a syncopal event, they've actually lost consciousness, what are you going to rule out? Something deadly called ACS or PE as the cause. Then we talked about palpitations, and we talked about benign palpitations, which everyone has, and this is a change in the rhythm of your heart, where it's delayed for a second or a millisecond, and then the left ventricle is full of blood, and when it goes to pump out, you feel that. And then we talked about pathological palpitations. The most common pathological palpitation that you're going to see, especially in persons over age 75, is what? Atrial fib, correct? The other is, the next is, since I love flow charts, I just thought I would show you that I have a flow chart for everything, and some of us need it. Tachycardia, I'm not quite sure what you're asking. We talked about, yes, PVCs and PACs are benign for many people, palpitations. Tachycardia is a fast heart rate, and we talked about that. The goal of a heart rate is what? For anyone, 60, as close to 60 as possible. Not 60 to 100, not 80 to 100, it's 60. 80 to 100 is too fast. Remember, I told you there's a theory that your heart's only going to beat so many times a minute in your life. So if a heart's beating at 60 times a minute, you're going to last longer than 80 times a minute. Yes, the oxygen demand increases, but I'm just trying to say your heart rate, your goal is to get a heart rate at 60. And I talked about what are the heart's response to increased demand for meeting the metabolic demands of the body, and that was tachycardia, which is an increased heart rate, hypertrophy of the heart, which is thickening of the left ventricle. It's not compensatory, and then ballooning of the left ventricle to, and that's the Frank Starling law, to increase the pump effectiveness of the heart, but that's not compensatory either. So 3 compensatory mechanisms of the heart. You're not going to be asked that on the midterm. Then I talked about edema, and your goal is to determine pitting or non-pitting. You should know the difference between 1, 2, 3, and 4 pitting edema and what it means. Usually in the elderly, what is the cause of pitting edema? It's multifactorial, meaning valvular incompetence, fluid, lack of activity, weight, multifactorial. Fluid overload is not the main cause of edema in the elderly, by the way, unless they have compensated or uncompensated CHF. But when I see edema of the lower extremities, my first thing is not CHF, by the way. And you can think about it, but it's fluid load in the lower extremities, usually due to valvular incompetence. My point being, in edema of the lower extremities, you think there's probably multifactorial components, and that's your goal. Once again, leg edema. So for the midterm summary, we talked about lab tests, why, what were the values, sensitivity, and specificities, how do we do some common tests on organs or diseases, i.e. anemia, respiratory, inspect, palpate, percuss, and auscultate. Somebody comes in with dyspnea and you want to know the degree of dyspnea. With asthma, we think about wheezing. With COPD, we think about emphysema and bronchitis. For both asthma and COPD, you stage it and you have an action plan. Then we talked about chest pressure, and you want to rule out the deadly cause of chest pressure, whether it's respiratory or cardiac, and you don't know, and that would be acute coronary syndrome, and that would be a PE. In cardiac, we inspect, palpate, auscultate. We listen to normal heart sounds, which are S1, S2. We listen for S3, which is CSH, CHF, diastolate, fluid overload, S4, which is ACS, acute coronary syndrome. It's called a gallop. We look for murmurs. Mitral regurg, aortic stenosis are the most common. They're found in systole. It's due to either an incompetent or a stenotic valve. We talked about chest pressure again. We talked about hypertension as the leading cause of coronary disease. And then we talked about modifiable and non-modifiable risk factors for hypertension. Hypertension is 2 or more blood values above 140/90. We talked about cardiac risk factors for you to determine what is the risk in a 10 or 20 year for cardiac event and can they change that. We talked about syncope. What are the 2 leading causes that you want to rule out in frank syncope, meaning they've lost consciousness? We talked about palpitations, benign, which would be PVCs, PACs, and non-benign or pathological, which the most common is atrial fib. We talked about edema, pitting, and non-pitting, and most pitting is multifactorial. So that's all for me, and your turn, Ellen.
Okay, can everybody hear me? Okay, thanks. This is going to be really short because I only have most of the midterm will be on what Kathleen just went over for cardiac and respiratory. And then there's just a couple questions on HENT and breast and thorax. Okay, so you have somebody comes in with seasonal rhinitis, watery, itchy eyes, clear nasal drainage, inflamed conjunctiva, sneezing over and over again, especially after they wake up in the morning, a tickle in their throat, itchy ears, nose, and throat. What other questions would you like to know? Yep, allergies. Onset, how long they've had it. Fever, cough. Yep, seasonal allergies, meds taken to alleviate it. And if they've worked, how about, does anybody at work and at home have similar symptoms? So what makes it worse? Yep. So when you're going to focus your assessment, how are you going to focus it? What are you going to do? You could do transillumination like we talked about. You can palpate the face and percuss the face and the sinuses. Yep, you're going to ask them if there's any drainage, any nasal drainage, any consistency, breath sounds. Have they been coughing? Yep, you're going to check their lymph nodes, palpate and transilluminate, check the turbinates. Yeah, any lab tests that you'd want to do or that you could do? CBCD, yeah, CBCD you do. If persistent, yeah. You want to see if there's a white blood cell count. You can check the eosinophils, stuff like that. Other things you could do if this was something that was occurring quite often, you could do a RAS test to look for allergies. And what would your differential diagnosis be? Check for postnasal drip. Yep. Differential diagnosis. Upper respiratory infection. Yep. A rhinitis, acute rhinitis, probably an allergic rhinitis, probably an allergic, it could be an allergic conjunctivitis because they have inflamed conjunctiva and a rhinitis together. A lot of times they'll go together. Okay, good. Okay, otorrhea, discharge from the ear. So in order to diagnose the cause of this drainage, it's important to know how long it's been occurring, how severe it is, and exactly under what circumstances that it began. What else do you want to know? Virulent or serous? Does anyone know if this is posted anywhere? Yes, they will be posted. We'll talk about it after. Pain, fever, trauma? Yep. What other questions would you ask them? Balance, yes. Any dizziness there at all? History of foreign body? Yep. So when you focus, you're going to want to look in their ears, right? And what are you going to look for? Discharge, swimming, ear drains, yep. You're going to look at the tympanic membrane, see if there's any pain, any bulging fluid, yep. Any perforation in there? Erythema, yep. Big thing is you want to know, is there any dizziness that they've, any nasal drainage too, any itching in their ear? How about, has their hearing changed? Have they noticed a decrease in hearing? Light reflex, yep, you're going to look at that. Can you see the bones grossly intact? Yep. Okay, good. Level of consciousness. Dizziness, you want to look for, if somebody comes in and complains of dizziness, what kind of things are you going to ask them? Vertigo, fever, yep, BP, medications, any medications that they're taking. Visual changes, yep, room spinning, worse when they look down. Precipitory factors, head injury, worse when standing up. Brief episodes when turning their head. Gaits. So what kind of things what would you be in your differential diagnosis for this? Yeah, you do orthostatics, especially if you have somebody on blood pressure medications. You want to do orthostatics to see if there's a change, because you might have to adjust the dosage. Otitis media, what else? Vertigo versus SOM, vertigo. BP, PV, benign paroxysmal, I can never say that one, benign paroxysmal positional vertigo is a big one. Meniere's disease would be another one. Serous otitis media. What about medication induces? Yes, exactly, and that's why you're going to do blood pressures. You can also look at other medications. The other thing you're going to ask them, especially if they're elderly, do they get up fast? You know, and you need to talk to them about changing their position slowly so that, you know, the baroreceptors can actually catch up to their movement so that they don't get as dizzy. This is just, I just brought this back up. It was in the breast and thorax lecture. The breast screening recommendations for women at average risk. And like I said, the American Cancer Society for mammogram is every year starting at age 40. National Cancer says every 1 to 2 years starting at age 40. The National Comprehensive Cancer Network agrees with the American Cancer Society. And the U.S. Preventive Task Force is informed decision-making with healthcare provider ages 4 to 49 and every 2 years ages 50 to 74. And then your clinical breast exam is every 3 years ages 20 to 30 and every year starting at age 40. No specific recommendations for the National Cancer Institute, and the U.S. Preventive Task Force says there's not enough evidence. The National Comprehensive Cancer Network says every 1 to 3 years ages 25 to 30 and every year starting at age 40. And when they come in, girls come in their 20s, I know I do it, I always talk to them about self breast exams, and I know it's out there saying that that it doesn't, it's not really that great of a diagnostic tool. But I always tell them it's good to know their breasts, to check their breasts like 1 to 2 weeks after their menses, and go. I show them how to do it. I have them do it, and I tell them to do it monthly. Do it every other month if you don't want to do it every month. But just to get to know them, because I've had girls come in that have found lumps, and we've done tests on them, and most of them have come back benign. But still, I might not see them for another 2 years, but that brought them in. So it really is a good thing. Which recommendations might you be looking for on the exam? I would just look at this. I'm not, anything that I tell you in here tonight should help you. The other thing we talked about was the different ways of doing a breast exam. There was a circular, there was a lawnmower, there was a spoke, there was, I think, another one too. But the National Cancer Institute standard says a best practice method of an annual clinical breast exam includes an ungloved hand, and the lawnmower method is what they recommend. I thought the silk fabric was interesting. Yes, the silk fabric was interesting that the Kathleen spoke about. However, she's not on the quiz, on the test. So if somebody comes with a sore throat and hoarseness, what questions would be included that you'd be asking besides onset and duration? What else? Any cough when it started? Yep. Fever? Smoke? Yep. Exposure to others with the same symptoms? Yep, excellent. Any tobacco products? Allergic reaction? Yep. Headache or cough? Can they swallow or drink? Does it hurt? When I have somebody come in and I'm looking for strep throat, the one thing I always ask them, only because I've had strep throat, is it painful just to think about swallowing your own saliva? Because most people who have strep throat, they can't even do that. The pain is so bad. And if they say to me, nah, it's not really that bad, it's not to say that they still don't have strep throat, but it's always that's just one of the things I've always asked them. Cough, GERD, nasal congestion, yep. Live or work with others with the same complaint, yep. Very good. So these breast cancer, leading cause of death in women between 35 and 65. And second, only to heart disease in women over 65 is an important thing to remember. Do symptoms worsen depending on the time of the day? Yeah. That's actually a good question, because sometimes it's worse first thing in the morning and then later on in the evening, I've found. Okay, and then just different definitions. So you have the areola, which is the small darkened area around the nipple of the breast. Pure d'orange is the skin of the breast will thicken and pit slowly, usually with noticeable lumps and pain. It looks kind of like an orange skin. Pectoral anterior lymph nodes are located at the lower border of the pectoralis major, inside the anterior axillary fold, and they drain most of the breast and the anterior chest wall. The brachial or lateral nodes are located in the upper humerus and drain most of the arm. The subcapsular or posterior nodes are located in the lateral scapular border and deep in the posterior axillary fold, and they drain the rest of the arm and the posterior chest wall. And when you do a breast exam, you have them sit up and do the stuff, but the best position to actually do your breast exam is having them supine. I'll send you I was wondering the same thing, because I have to look at the question, but because I know the answer, but I can't think of the question right now. But I'll get back to you with those answers.
Usually, though, Ellen, it's the skin texture. It's not the color in poudre d'orange. It's the skin texture, thicken and pit, not so much the color. And
it looks like the skin of an orange. How it's not smooth. And actually, that's the end of it. I will post this. Where do you think we should post it, Kathleen?
Actually, I already sent it to everybody on there. I went to messages, Ellen, and I sent it to everybody. And I will post it in, what week is this? Is week 6? I will post it in week 6, if that's helpful. But they've all gotten it in their email.
Okay, all right.
Does
So
that
I'll
work
post it
for
in
you,
week 6.
Ellen?
Yeah, actually, that does. So I think if you look
you
at
could just send it on the email, and then it's not part of the course, which might be our best bet, Ellen. Does that make sense?
Okay. Okay, yeah, I can do that.
The test is 40 questions and 12 from respiratory, 12 from cardiac, 4 from lab, and then that's 12 and 12 is 24, and 4 is 28, and then 12 from Ellen. What is it? 4 for breast, Ellen, and 4 for HENT.
No, it's 6 and 6. It's 6.
6 for breast and 6 from HENT. It's 40 questions and you have 90 minutes. There's matching and multiple choice. All right, once again, the cardiac is archived. The respiratory is, yes, it's on Monday for 24 hours. And so next week, I will also archive that. It may not be till Tuesday. And then the following week, we'll have musculoskeletal, and we'll just meet at the regular time. So thanks. 14 days, 10 to 14 days for grading papers. Thanks. Good night. Good luck on your test and enjoy this week.
Good night.
Good night.